What's up, guys? Today we're going to talk about acute cystitis and acute pyelonephritis. We're going to talk about how these patients will present, the physical exam, what are the common pathogens, and finally, how do we treat these patients? Acute cystitis can be defined when the normal sterile tissue of the bladder becomes infected, causing a lower urinary tract infection, whereas acute pyelonephritis can be defined as an infection within the renal parenchyma, calyces, or pelvis of the kidney, resulting in an upper urinary tract infection. In addition, acute cystitis can occur alone or along with acute pyelonephritis. But what causes these infections most commonly? Well, in women, lower urinary tract infections occur when uropathogens from our own feces colonize within the vaginal enteroides. From there, they can then travel into the urethra and into the bladder, causing acute cystitis. From here, if the uropathogens continue to ascend up the ureters to the kidneys, pyelonephritis can develop. Pyelonephritis can also be caused from bacteremia if the pathogen seeds within the kidneys. The most common causes of acute uncomplicated cystitis and pyelonephritis occur mainly from E. coli, 75 to 95% of the time. Occasionally, you will have other species found in the normal flora of our stool causing these infections, such as Proteus mirabilis, Klebsiella pneumoniae, and Staphylococcus saprophyticus. Complicated acute cystitis and pyelonephritis microbiology includes the above organisms that we just spoke about most commonly, but it also involves a broader spectrum of pathogens to include Pseudomonas, Seriata, Providencia species, and even fungi. So now we know the most common causes and how they occur most frequently, but how will these patients present? Well, as with all patients, before you enter the room, take a look at the triage note and review the vital signs. Do they have a fever? Are they tachycardic, hypotensive, hypoxic, with an increased or decreased respiration rate? Next, start off by taking a good history. Typically, patients with acute cystitis will complain of dysuria, frequency, urgency, suprapubic pain, and even hematuria. However, keep in mind that the symptoms of acute cystitis can be subtle in the very young or old individual, and their only complaint may be weakness or back pain. Now I want you to pause for a moment and think about the pathophysiology that we just discussed earlier for pyelonephritis. Since pyelonephritis can occur from the pathogen traveling up the bladder to the ureters, patients with pyelonephritis will also complain of dysuria, urgency, frequency, suprapubic pain, and hematuria. However, now these patients with pyelonephritis will have additional symptoms of fever greater than 100.4 degrees, chills, flank pain, nausea, and vomiting. In addition, acute pyelonephritis does not always present by the book, and it can occur without typical symptoms of acute cystitis. And in the older individual, they might only have a very low-grade fever of 99.6 degrees Fahrenheit and just flank pain. On physical exam, patients with acute cystitis might have mild to moderate suprapubic pain to palpation, or CVA tenderness and vomiting if pyelonephritis is the cause. Now, let's talk about how to work up these patients. An otherwise healthy adult female patient with typical symptoms of only acute cystitis, one can argue that a urine dipstick or urine analysis isn't even necessary. This is because this is largely a clinical diagnosis. So you can either do a urine dipstick if you're in the office setting or a urine analysis in the ED to confirm your diagnosis, but you might not even need to. However, if the patient presents with lower urinary tract symptoms and signs of upper urinary tract involvement, such as vomiting, nausea, CVA tenderness, flank pain, and fever, you need to order a CBC looking for an elevated white blood cell count with a left shift, a CMP looking for any electrolyte abnormalities from excessive vomiting or dehydration, and a urine analysis with culture. So quickly, let's talk about how to use the urine analysis to support our diagnosis of either acute cystitis or pyelonephritis. In acute cystitis, you will see positive leukocyte esterase, a positive nitrite, increased white blood cell count. You might even see squamous epithelial cells. However, these are part of the normal flora of the distal urethra and external genitalia, and their presence represents contamination from genital secretions. This is very important, guys, and it confuses my students all the time. If you have too numerous to count squamous epithelial cells and only 20 to 50 white blood cells with 1+ bacteria and negative nitrite and negative leukocyte esterase, you have to consider other diagnoses such as STDs or a contaminated catch, and the urinalysis should be repeated with consideration of doing a pelvic exam. So in the patient with pyelonephritis, you will have a positive nitrite, leukocyte esterase, lots of white blood cells. However, now you will have white blood cell casts in the urine indicating renal involvement, but white blood cell cast may not always be present. So how do we treat these patients? Well, in the uncomplicated, non-pregnant female, these patients should be treated with either nitrofurantoin, also known as macrobid, 100 milligrams BID times 5 days, or they can be treated with trimethoprim, sulfamethoxazole, also known as Bactrim, one double-strength tablet with 160 milligrams of trimethoprim, 800 milligrams sulfamethoxazole, 2 times a day for 3 days. But how do we treat these patients with uncomplicated pyelonephritis? Well, in these patients, they should be rehydrated with fluids, typically 1 liter of normal saline or lactated ringers. Then you want to make sure you are treating their nausea and vomiting with either Zofran or Phenergan. And prior to discharge, you need to give these patients a PO challenge and make sure they can tolerate oral fluids. This is because if they cannot keep down fluids after the antiemetics you gave them, they're just going to puke back up their oral medications you're going to send them home on. And you also have the option of giving them 1 gram ceftriaxone IV or 1 gram IM if you're in the office setting, and a PO pill of either ciprofloxacin or levofloxacin in the ED. So in my typical practice, in the uncomplicated pyelonephritis, I give 1 gram ceftriaxone and 500 milligrams Cipro PO. Then I document in my chart they are able to tolerate oral fluids, and I send them home with a prescription of Cipro 500 milligrams BID times 7 days, or levofloxacin 750 milligrams daily for 7 days, and a prescription of Zofran for nausea. But how do we treat those patients who have complicated cystitis or pyelonephritis, which can be defined as someone who has an underlying condition that increases the risk of failing therapy? You can remember patients with complicated urinary tract infections by the mnemonic failure, PH, where F stands for functional or anatomical abnormality of the urinary tract, A stands for acute kidney injury or chronic kidney disease, I stands for immunosuppression, such as chronic steroid use, chemotherapy, neutropenia, or HIV, L stands for living intrauterine pregnancy, U stands for urinary tract obstruction, so maybe they have an obstructing kidney stone, R stands for renal transplant, E stands for endocrine, as in the poorly controlled diabetic, P stands for presence of an indwelling catheter, stent, nephrostomy tube, or urinary diversion, and H stands for a hospital-acquired infection. So in the non-pregnant female with complicated cystitis who can tolerate oral therapy, you will want to treat them with ciprofloxacin 500 milligrams twice a day for 7 days, or levofloxacin 750 milligrams daily for 7 days. However, how do we treat the patient with complicated pyelonephritis? Patients with complicated pyelonephritis should be managed initially as inpatients, especially if they're still having vomiting and a high fever. Initial inpatient therapy for mild to moderate pyelonephritis can be treated with either ceftriaxone 1 gram every 24 hours, ciprofloxacin 400 milligrams every 12 hours, levofloxacin 750 milligrams every 24 hours, or aztreonam 1 gram every 8 to 12 hours. Severe pyelonephritis can be treated with multiple different options to include cefepime 2 grams every 12 hours, piperacillin tazobactam, also known as Zosyn, 3.375 grams every 6 hours, or a number of different carbapenems. Quickly, let's take a brief second to tie up one loose end. Commonly, pyridium can be described for the symptomatic relief of dysuria. However, since clinical manifestations of burning on urination should respond to antimicrobial therapy in 48 hours and typically resolves in a few hours after the start of therapy, you should not prescribe pyridium for more than 2 days. This is because pyridium masks the clinical symptoms of dysuria. So for example, let's say you prescribe a 5-day course of pyridium and macrobid for acute cystitis. Well, the patient's symptoms of dysuria may have resolved, but what if their urinary pathogen was resistant to macrobid? Then they falsely believe that their UTI is gone, and it replicates for 5 days, possibly ascending up into the kidneys and causing pyelonephritis. So if you're going to prescribe pyridium, only prescribe a short course of 2 days and educate the patient that this will cause a reddish and orange discoloration of the urine. So that's everything we're going to talk about today. If you're new to the podcast or YouTube channel, consider subscribing now for weekly podcasts and videos. If you have any questions, please do not hesitate to email me at gray@physicianassistantboards.com. That's GRAY@physicianassistantboards.com. Until next time.